Jasmin Hundal. I'm a current third-year hematology and oncology fellow, graduating from the Cleveland Clinic. ASCO 2026 was an exciting meeting for breast cancer with important advances across both metastatic and early-stage disease. And so today we'll be focusing on some studies that had updates during the conference. So first we'll dig into metastatic triple-negative breast cancer. One of the biggest stories from ASCO was the continued evolution of antibody drug conjugates, or also known as ADCs, in metastatic triple-negative breast cancer. The TROPION Breast-02 clinical trial evaluated Dato-DXd in the patients with metastatic triple-negative breast cancer who were not a candidate for PD-1 or PD-L1 inhibitors. The study, as we know, had already demonstrated improvements in progression-free survival and overall survival with chemotherapy, leading to FDA approval early this year. And at ASCO 2026, we saw important updated data showing continued benefits from multiple clinically meaningful endpoints. The median time to first subsequent therapy or death improved from 5.6 months with chemotherapy to 10.9 months with the Dato-DXd, and also the time to second progression and time to subsequent therapy were also significantly improved. Importantly, this was a frontline metastatic population, and the benefit really persisted to a higher proportion of patients in the chemotherapy arm later receiving ADCs as well. The other study that I'd like to highlight was the ASCENT-04, which is known as, which evaluated Sacituzumab Govitecan plus Pembrolizumab versus chemotherapy plus Pembrolizumab in patients with previously untreated PD-L1 positive, locally advanced, unresectable, or metastatic triple-negative breast cancer. This trial previously demonstrated again a progression-free survival benefit with a median PFS from 7.8 months with chemotherapy plus Pembro to 11.2 months with Sacituzumab Govitecan plus Pembrolizumab. And in 2026 ASCO, investigators presented important follow-up analyses examining the progression-free survival after next-line therapy, also known as progression-free survival 2, PFS2, which is a useful endpoint when overall data, survival data remains immature and crossover is common. So the median PFS2 was not reached in the Sacituzumab arm compared with 21 months in the chemotherapy arm, translating to a 33% reduction in the risk of progression on subsequent therapy or death. Notably, this benefit was also observed despite substantial crossover, with approximately 81% of patients in the chemotherapy arm who received subsequent treatment ultimately receiving Sacituzumab Govitecan. Additional data that was presented, median time to first subsequent therapy improved from 9.8 months to 17.3 months, and patients experienced a longer duration of disease control requiring additional treatment. So this really strengthens the case of Sacituzumab plus Pembrolizumab as a frontline standard of care for patients with PD-L1 metastatic TNBC, suggesting the benefits extend beyond first progression. Taken together, these studies established two highly active frontline ADC options for our patients, whether PD-L1 eligible or ineligible. And really the next challenge will be determining how to best sequence these agents and identifying which patients may derive the greatest benefits from each strategy. Now moving to our endocrine therapies. So for example, the VIKTORIA-1 trial evaluated Gedatolisib plus fulvestrant with or without palbociclib in patients with PIK3CA mutated hormone-positive, HER2-negative metastatic breast cancer following progression on a CDK4/6 inhibitor. The Gedatolisib plus fulvestrant doublet improved median progression-free survival from 5.6% with alpelisib plus fulvestrant to 11.3%, which was almost a doubling of the PFS. The triplet arm achieved very similar outcomes as well, suggesting much of the benefit could be coming from a deeper inhibition of the PIK3-AKT-mTOR, also known as the PAM pathway. Equally important was the safety profile. The hyperglycemia occurred 11 to 15% in patients receiving Gedatolisib, whereas 58% with the alpelisib, and the rate of diarrhea were also lower. For years, we know alpelisib has limited use because of the toxicity, despite its proven efficacy. And VIKTORIA-1 trial really suggested that we might have a more tolerable, highly effective method of targeting the PAM pathway in PIK3CA mutated disease. So this will be really exciting once it's approved. The other innovative study, as we know, is the SERENA-6. Traditionally, we wait for radiographic progression before changing therapy. SERENA-6 challenged this paradigm, right? It underwent serial ctDNA monitoring while receiving first-line endocrine therapy and a CDK4/6 inhibitor. When ESR1 mutation emerged, patients were switched from an aromatase inhibitor to camizestrant before clinical progression. The results are really astounding. Approximately 51% of patients achieved ctDNA clearance compared with only 1.9% in the control arm. This study really provides a compelling proof of the concept, where we may be able to intervene earlier when resistant emergence at a molecular level rather than waiting for radiographic progression. But again, we're still pending regulatory approval, but this will be definitely a truly biomarker-guided endocrine therapy once approved. Lastly, is the PRESERVA phase 3 clinical trial with giredestrant plus palbo versus letrozole plus palbociclib in the first-line setting. And the median progression-free survival really favored the giredestrant, although the study didn't meet its primary endpoint. The key takeaway is the oral SERDs have not yet clearly demonstrated superiority, but we do see promising outlook for these. Going on to early-stage breast cancer, several important studies focused on improving outcomes while reducing the toxicity and overtreatment. The lidERA trial had early-stage disease in the phase 3 clinical trial. It evaluated giredestrant versus standard endocrine therapy in more than 4,000 patients with high-risk hormone-positive, HER2-negative early breast cancer. We did see that it reduced the risk of invasive disease recurrence by 30%, and among premenopausal, the risk was 35%. And among postmenopausal women, the risk was reduced by 26%. What makes these data particularly compelling is the benefit was observed across menopausal groups, but also improved tolerability. Treatment discontinuations due to musculoskeletal pain were reduced by more than a half compared to standard endocrine therapy. And this is really important because we do know adherence is one of our biggest challenges that we see in the adjuvant endocrine therapy. So the lidERA trial may be a major advancement in our adjuvant endocrine therapy in several years. Another important study that I'd like to highlight is the OPTIMA trial. This trial demonstrated that chemotherapy could safely be omitted in selected patients with genomically low risk, node-positive or hormone-positive disease, including some patients with N2 disease. For postmenopausal, these findings supported further treatment de-escalation. For premenopausal, the study really reinforced an important concept, but additional studies are definitely needed for this population. Then finally, it would be the reduced study examining denosumab dosing strategies in patients with metastatic bone disease. This demonstrated administration every 12 weeks after induction was non-inferior to every 4 weeks for preventing scalp-related events. Importantly, less frequent dosing was associated with reduced hypocalcemia, reduced osteonecrosis of the jaw, and substantially lower treatment costs. This is a simple example of how smarter treatment scheduling can really improve the value without sacrificing efficacy. Lastly, that I'd like to highlight is our most discussed topic, GLP-1 receptor agonists. There were several studies presented at ASCO. Real-world analyses suggest approximately 43% reduction in metastatic progression and 30% reduction in mortality among hormone-positive, HER2-negative disease while receiving endocrine therapy and CDK4/6 inhibitors who were also treated with GLP-1 receptor agonists. However, it's important to note that really these data are all observational and should not change practice today. We really need prospective studies are critical because we need to determine whether these findings represent causation or association. But it's very exciting with how GLP-1 receptors could have a biological effect beyond just weight loss. So overall, ASCO 2026 was a very exciting conference with some meaningful data that we saw and giving us directions and providing treatment guidance for our patients. Thank you.